Hello everyone. Okay, I'm doing my online class for differential diagnosis for low back pain, mainly for my colleagues who are physiotherapists. One of my very interests in my practice is differential diagnosis because I like watching Dr. House. That's why any single conditions, if I can do my best to do the anatomical pathological diagnosis, I prefer to go for it before the impairment approach. So I hope this online class can give you some ideas, especially the junior colleagues, how to do a differential diagnosis for low back pain. Okay, first of all, it is mainly a kind of sharing clinical experience. This one is not the formal academic teaching. Most of the content, I think, more clinical experience rather than evidence. Of course, I will share some evidence as well, but it's more clinical experience based. And for some people, if you are not physiotherapy or not medical professions, if you are patients, okay, this video may not be for you. Okay, so don't watch the video and think that you do the differential diagnosis for yourself. Consult your physicians or consult your therapist. And then for my colleagues, please feel free to point out any inaccurate information or copyright issue, if any. So, as mentioned earlier, I prefer anatomical and pathological based clinical reasoning. Of course, we know that in our practice, we have a lot of different paradigms in clinical reasoning, such as movement impairments, physical diagnosis, biopsychosocial approach, and chronic pain management for low back pain. Okay, I totally agree with that, but just this online class, I focus on the anatomical, pathological based clinical reasoning. And for clinical reasoning, the very foundation we learned there are two approaches. The very basic one is the hypothetical deductive approach, but I prefer to use the clinical pattern approach. That's what I had my intensive training in my master course. Okay. This one, the low back pain concerning in this online class are more about the acute and subacute management. For chronic low back pain, we prefer to go to chronic pain approach, which is relatively, I think myself, is relatively straightforward chronic pain approach. So, as I mentioned, I would like to share more clinical experience, but before that, I still talk something about evidence-based practice because I'm working in a university, a physiotherapy school. Clinical experience is important, but evidence-based training we need to respect absolutely. Okay. I need to remind some of your colleagues nowadays. More and more colleagues well aware of the evidence-based practice, but just my advice don't think it's a gold standard. Don't think evidence-based practice is a Bible. There are still disadvantages in evidence-based practice. I will go over later. Nowadays, a lot of assessment tools have been developed for the assessment of low back pain. This one I strongly recommend to you. It is called the Star Back Screening Tool. It consists of simply 9 questions, and it can help you to classify patients into different categories, and so the clinicians can prescribe suitable management for them. And this is the latest one. It's called NICE Guideline by Australian Physiotherapy Association. It also provides a flow chart for the clinicians to manage the patient with different types of low back pain. As you can see, by this screening tools, evidence-based practice, the diagnosis is not strongly emphasized. It's just focus more on the flow and the different classification of low back pain, I can say the by using these screening tools and protocols, our work can be more straightforward. I'm not downgrading clinical reasoning, but clinical reasoning varies from clinician to clinicians. Of course, more experienced clinician can do better clinical reasoning to have a better clinical outcomes from the patients. If we use the standardized protocols, at least we can guarantee some response from our patient. And not only the classifications but also the treatment. Nowadays, a lot of good meta-analysis, systematic review, or even clinical guidelines have provided recommendations for the treatment of low back pain. For example, acute low back pain, regardless of the diagnosis, just make sure they are stable, not clinical red flags, and it showed that education, a healthy lifestyle, stay active, and pain relief modalities, and even McKenzie exercise are good for acute low back pain. Refer to the evidence-based practice for chronic low back pain. I said should be very straightforward. Yes, this is true. If you look at the systematic review, meta-analysis, and clinical guidelines, the chronic pain management is even more straightforward. Stay active, exercise, exercise, and exercise. No, regardless of the diagnosis of low back pain. So simple, straightforward. Why not? And of course, evidence-based practice is not everything. It's not the Bible. It's not the very gold standard. There are some disadvantages. For example, there are some weakness in methodology, and there are some bias. Okay, publication bias mainly, and also the trend or evidence change from time to time. For example, previously, some very good journal or BMJ, okay, they show that chronic for management for chronic low back pain, okay, physiotherapy treatment is not superior to verbal advice from medical professions, or even you see the for tennis elbow for long-term outcome, physiotherapy is not much superior to wait and see. Do you believe in this kind of evidence? So still, we need to keep a critical mind to the evidence, and also I want believe uh, evidence-based approach. If these are correct, they should have no conflicts with clinical reasoning-based approach. Okay, why not we do two together and yield a better result? Okay, now we go to the main part of this online class. It's about the clinical reasoning-based practice. Before we do the differential diagnosis, okay, we need to look at two main things. First, yeah, as we all know, we study in the undergrad, red flags. Make sure there's no red flag. Okay, and the red flags I don't mention in details here. And low back pain should be lah. Okay, better to be musculoskeletal or oriented. Then we can have more roles on it. Um, if the systemic one, I think maybe better medical management. Okay, sometimes a neuropathic one. Okay, just refer to the red flag. Okay, we do the surgical management, or if not that unstable. Okay, even neuropathic, okay, we will do for it. Have you ever thought, okay, differential diagnosis is for low back pain is very difficult, or you think it's very straightforward because I use evidence-based approach? So acute, advice, stay active, hot pad, chronic, exercise, exercise, exercise. Okay, even I can tell you, even we do the anatomical pathological based clinical reasoning, we use the clinical patterns approach. Beside the non-specific low back pain, I think 70% to 80% of the low back pain can be well classified in the clinical patterns. And let's see how many patterns here you can see. 11 patterns. Okay, actually it's a manageable number, right? If you do the clinical patterns approach, you can definitely, if they are the specific low back pain, it is not difficult to put them in the proper categories and do the proper management. Okay. For differential diagnosis, there are some key points in the examination. I will pay more attention to it. From my experience, I can share some key points. One of them, is the onset. Of course, most of the pathologies they have the acute and chronic stage, but in some conditions, the acute stage is more prominent. Okay, the patient can definitely tell you that they have this kind of acute onset, sudden onset. For example, compression fracture, definitely we should have a traumatic event, and discogenic back pain, the patient should be able to tell you that coughing, wheezing, or sudden onset. And I will highlight muscle strain and joint sprain. Don't think they are very simple, inclusive diagnosis. My own experience, I injured my back muscle, okay, after exercise, and then I did not realize that, and I consulted three of my colleagues who were very experienced physiotherapy. We also look into the neuropathic things, chronic pain, and the joint things, and then we just missed the muscle strain. It was a delayed onset of muscle soreness. So, no matter how experienced we are, don't underestimate the simple, straightforward diagnosis. And those are the chronic condition or gradual onset on the right side. Okay. Go to the body chart. I classify low back pain into three categories. One is the local back pain. Local back pain means they have no significant referral pain. The pain only mainly in the local area. Okay. The origins of the problem should be around. It's relatively simple, straightforward. And butt topping, I like it. Butt topping is a signature of particular two conditions. One is the SI joint, one is the piriformis syndrome. Okay, only these two conditions, the patient can concretely tell you that I have butt topping. And you may also think, is there a possibility of nerve root impingement because the buttock is on the dermal tone is referring to the lower region of the mainly L4, 5, or even S1, 2. So you can simply consider SI joint origin. Sciatica, or you can also think this referral pain are not necessary to be sciatica. Okay, referral pain down to the leg. Okay, so can be discogenic pain. And why I always put spondylosis, spondylolisthesis, not spondylosis together, because I think they are instability problem. The presentation and the management are more or less the same, so I put them together, which is easier to manage. Okay. And nerve root compression. Okay, don't forget SI joint and piriformis. They also have the referral pain. Okay. In the objective examination, I will look at two things in the range of movement and the pain of onset. I will look into the open joint pattern and closed joint pattern. Basic idea. Open joint patterns mean that the patient they have pain in flexion and side flexion to the contralateral side and rotation to the contralateral side. Okay, because in these three physiological movements, it seems that the intervertebral joints are opening. Okay, so we call it open joint patterns. And discogenic back pain, piriformis syndrome, muscle strain, considered as open joint patterns. They are very typical. Nerve root compression, usually the people think are more the closed joint pattern because in extension closing the intervertebral foramen. But remember, sometimes if nerve root compression, there are some tension on the nerve. If you do the open joint patterns movement, there is a chance that they may stretch the neural tissue. Okay, so I put the nerve root compression on both open joint and closed joint pattern. As mentioned, the closed joint patterns should be extension, side flexion to the ipsilateral side, and the rotation to the ipsilateral side. Okay, just remember in this way. All the joint problems are considered as the closed joint patterns. Okay, so simple, straightforward. Okay, once you look at the onset and uh, demographic data and movement patterns which trigger the pain, you should have some ideas to include about 3 to 5 hypotheses. At this moment, okay, you further look at the special features of each clinical pattern. For example, for the lower thoracic joint or the thoracic joint pain, okay, because rotation of the spine happen the most in the thoracic joint rather than the lumbar. Lumbar do more the side flexion. So that's why if you suspect the thoracic, ask the patient to do a rotation in sitting. Okay, the pain should be more prominent in this action. And also because the thoracic area involves the costovertebral joint, ask them to do a deep breathing at the end and hold at the end, see any mild change in the symptoms. Okay, for nervous compression, of course, it's very obvious. You see any the referral pain if there is any dermal chone or mild chone pattern. Okay, we refer to the spinal segment. Osteoporotic spine, okay, advanced age, increased kyphosis, diffuse pain. If your career in your own country is the direct asset model, okay, so you need to be aware of that. If some countries, the practice based on referral from the doctor, usually we are not that aware of that because the doctor will screen it out as a general health. Okay. Discogenic pain, okay, diagnosis acute onset, okay, the stressful features are coughing, sneezing pain, of course it's not inclusive, but one thing, when you do the straight leg raising, there may be a crossover sign. For sacroiliac joint, okay, beside the buttock pain, one main feature is that the therapist may need to ask specifically the patient, when you turn to a side on back, do you feel the pain? I could not find the picture on internet, but I can just say, if the patient want to turn to a side, okay, usually they use the contralateral leg to push backwards. Okay, at this moment when they push backwards, it stress on the sacroiliac joint and trigger the pain significantly. So in the special questions, if you suspect it's a sacroiliac joint pain, you should ask the patient, when you turn on bed, when you do a turn on your bed, do you feel pain on your buttock? Piriformis syndromes, of course, is also buttock pain, but because this is a muscle, the onset is not that mechanical. Usually, in standing, it takes some time to start to feel the symptoms. And also, I will ask if I suspect it is piriform syndrome, not the joint. I will ask the patient, in your work, do you need to stand for a prolonged period? Okay. Do you have a habit to tend to stand on one side more? Okay. Those are the cues for piriform syndrome. Spondylosis and spondylolisthesis, those instability patterns, of course they present features of instability. A step deformity is a unique feature for them. And one more special feature is that if the pain is their main problem, when you ask them to do trunk flexion, okay, they may or may not have pain. But when they return from flexion to neutral position, the symptom will be provoked. Okay, so once you have the ideas in the SE and OE and look at the special features, you still need to have your special tests to confirm the physical diagnosis. Special tests are not necessarily the named test. Okay, any test can facilitate you to confirm the special diagnosis. Those are the special tests. For the spine, it can be as simple as the passive physiological intervertebral movement or passive accessory intervertebral movement. Yeah, those are very common and those are routine. And palpation, don't forget it because we need to palpate a lot of you need to palpate a lot of things. For example, for sacroiliac joint problem, you palpate the dorsal longitudinal ligaments. For piriformis syndromes, of course, palpation on the piriformis muscle. Okay. Even for named special tests, those are not very fancy at all. I cannot think a lot, but mainly two. For discogenic back pain, especially for acute, if they have the referral pain, you can look for any centralization phenomenon. This phenomenon was proposed by the Mackenzie approach, Robin Mackenzie. Is saying that if they have the discogenic back pain, we do some central maneuver, for example, extension exercise. The distal referral pain should shift towards to the central. That means that it decreases the area of the referral pain. Okay. And surprisingly, the research showed that this phenomenon score not bad sensitivity and specificity to for diagnosis of discogenic back pain. And sacroiliac joint dysfunction is very well known already. The pain propagation test. Two or three positive propagation tests prove the presence of sacroiliac joint dysfunction. But clinical experience tell us that usually if you find the pain at the buttock and you palpate the dorsal side longitudinal ligaments, there are some tenderness, and ipsilateral side L4-5S1 joint stiffness and pain, and also tenderness of the piriformis muscle. Okay, you can quite confirm this sacroiliac joint dysfunction. And yeah, uh, for diagnosis at the end stage, we need to provide treatments, right? As I mentioned, evidence-based approach, they are awesome. They are okay. They are nothing wrong. They are totally correct. Okay. For chronic pain, okay, just go and ask the patient stay active and do the exercise. But on top of it, we can still add some clinical reasoning. Now I'm staying the treatment principles only. The concrete treatments, I think it depends on the experience and training of therapists. Stay active exercise, chronic back pain, non-specific low back pain, nothing wrong. Okay, and make sure we don't have conflicts with the clinical reasoning approach. For example, in chronic low back pain, it doesn't stage any specific type of exercise. Maybe core stabilization exercise are better for low back pain. But if you ask the discogenic back pain patient to do more strengthening fashion exercise, it may hurt. We may focus more on the extension exercise for discogenic back pain. I just want to say, clinical reasoning-based prescriptions still apply. And joint mobilization manipulations are main manual treatments. Okay, for those joint problems, yeah, definitely we should go for it. But if you want to increase the successful response from the patients, there are some recommendations. And from the evidence, we're saying that if we want to do a good pain reduction by manipulation mobilization, the back pain should be not a chronic one. I won't say an acute one because acute is confusing. They suggest the onset of pain should be within 16 days. That will be better. And there are the fear avoidance beliefs questionnaire screening should be in a low score, and hip internal rotation should be more than 35 degrees on one side. You wonder why does it matter with the hip internal rotation? If you go through the literature, you may see that first, two reasons. I haven't gone through in very details. First is that indirectly refer to the SI joint mobility, and second, to screen out the pain and refer pain may not from the hip lah. And traction, okay. I myself, even I had my master training in Australia. I'm still a fan of traction. It works very well for some particular type of patient. If you find your patients have nervous compression symptoms, or even chronic is a chronic one, chronic discogenic back pain. The pain is originate from the back. Okay, they present a cross joint patterns, and then there's no movement centralized symptoms. Okay, you should go for traction. But you can see a lot of evidence say that traction not that useful or not that evidence based. I will question that is it a problem of traction or is it a problem of the evidence? Because most of this research they involve a very small group of patients, and also the homogeneous group is a problem. But as you know, when we conduct clinical research, the inclusion criteria usually is very general. But if it is too specific, okay, we can only include very few patients, then the sample size is small. So evidence-based practice also has disadvantages. And stabilization, core stability exercise, I think is very universal. As long as it is a chronic back pain or non-specific low back pain, I don't think it is anything wrong to prescribe the stabilization exercise. But to increase the effectiveness and you apply the clinical reasoning for exercise prescription, there are three conditions I think will benefit more from the stabilization exercise, including the instability patterns, sacroiliac joint problem, and chronic discogenic back pain. Okay, so if you want to refer to the reference, you can pause it here. Those are the references. Um, Thank you for attending my class. Hope it can help you to do a little bit better for your patients with low back pain. If you have any comments or suggestions, please feel free to contact me.